It takes heart to build bodies that break records. Over the last 6 years, a team of incredible healthcare professionals did what most people thought was impossible. They rebuilt the body of legendary Olympian Lindsey Vonn after a series of devastating injuries forced her into early retirement. Now she's headed to the 2026 Winter Games, ready to break records once again. This February in Milan, Lindsay's team and the entire USA medical team will be wearing FIGS. You can rock their official uniform too. The new Team USA collection from FIGS is engineered with Fiber X, the most durable fabric yet. Fiber X is the new gold standard for high-performance scrub wear. It's lightweight, breathable, and ultra-resilient. And of course, the styles come in red, white, and blue. Check out the limited edition Team USA collection and get 15% off your first order at wearfigs.com with code FIGSRX. That's wearfigs.com, code FIGSRX. Today's show is sponsored by strawberry.me. Do you ever feel like you're doing everything you're supposed to do, but you're still not totally clear on where you're headed? For a lot of nurses and nursing students, life can feel like a non-stop cycle of shifts, school, and responsibilities, with very little space to pause and think. But here's the thing. Success and fulfillment are built with clarity, with intention, and with follow-through. And many people get there with help. Coaching gives you a place to talk things through, whether you're feeling burned out, trying to set better boundaries, deciding what your next chapter looks like, or just wanting to feel more confident in the choices you're making. That's where strawberry.me personal coaching fits in. Working with a coach gives you clarity, strategy, and accountability, so you can sort through what matters, identify what's been keeping you stuck, and take meaningful steps forward. When your thoughts feel organized and your decisions feel intentional, everything gets lighter. Working with a coach has helped me define my goals, focus on what's most important, and absolutely skyrocket my productivity. Go to strawberry.me/nursemo and get 50% off your first coaching session. That's strawberry.me/nursemo. Get coaching for your career and your life. Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips to help you thrive in school and at the bedside. Today, we are diving into groin management. So, groin management is kind of nurse lingo, medical lingo for the care involved after a patient has had their femoral artery or the femoral vein accessed. This could be with a cardiac catheterization procedure or interventional radiology procedure. So what we're going to be focusing on is the nursing care after the sheath has been removed and hemostasis has been achieved. We're not going to go into all the nitty-gritty about sheath removal in this episode. That typically occurs in the procedural area. Not always, though. Some step-down units will pull sheaths, but we're not going to go into all that. That's a whole other thing. We're going to be talking about care after sheath removal, after hemostasis has been achieved. So looking at this from the perspective of that post-op nurse, your job is to maintain activity and bed rest restrictions, prevent bleeding, monitor for complications, and do what you can to keep the patient comfortable. You're basically managing that groin. So that's why we call it groin management. Now, before we dive into the details, let's do a quick review and answer some questions you may have. So you may be asking, what is a sheath? If you're brand new, you've never heard of it, that's a great question. A sheath is a hollow plastic tube, basically, that is placed into the vessel that's being accessed. And this provides a stable, continuous access port so that the interventional cardiologist or interventional radiologist can insert and exchange catheters and other instruments for various procedures without having to re-trauma the vessel over and over again. So you'll see it used in like cardiac catheterization procedures and a variety of interventional radiology procedures. Another question is, are sheaths arterial or venous? They actually can be either arterial or venous, so you will see them used in both vessel types. Also, you might ask, do sheaths come in different sizes? And the answer is yes, they do. Sizes range from tiny little ones around 4 French up to really giant ones for very complex specific procedures that are 24 French, but common sizes range around 6 to 12 French. Now, you might be thinking, wow, that sounds really risky. Then you are right. And if you're wondering what the potential complications are, these include bleeding. That's going to be the big daddy complication we're watching out for. It can definitely be life-threatening, especially when it's an artery that we're talking about. Hematomas can develop. We can get distal limb ischemia. We can get a pseudoaneurysm and even arterial dissection. So, quite a few potential complications. And if you're thinking about bleeding being something very serious that can occur, the risk factors for bleeding might be something that you're thinking about. So, the risk of bleeding is going to increase, of course, if the patient is on an anticoagulant or undergoing antiplatelet therapy. It's also going to be more risky if the sheath size is larger than a 6 French. And again, 6 French is a pretty darn common size. If the patient's female, over age 75, if the patient has obesity or low body weight, that's higher risk. Also, if they have peripheral vascular disease, renal disease, or thrombocytopenia, which is a low platelet count. Now that you've got a little bit of a background on sheaths and some complications and risk factors, let's dive into it using the straight A nursing LATTE method. And we'll start with the letter L, which is, how does the patient look? What are you going to notice about this patient? So what you will see after the procedure depends in large part how hemostasis was achieved. So some common ways to do this are a manual hold, using a mechanical device, using a vascular closure device, or suturing the vessel. So in a manual hold, this is where the nurse or a trained technician applies manual pressure, firm, consistent manual pressure to the site until hemostasis is achieved. And, with arterial access, this can definitely take a while. I've seen it take 20, 30 minutes. For venous access, it doesn't typically take as long, but it's a really long time to stand there and be placing that pressure on that vessel site. So we do see manual holds. They are a very effective way to do it, but they're not staff friendly, I guess I would say, because it does tie somebody up for an extended period of time. And arms, hands, fingers can get fatigued. So what you will see used a lot of times is a mechanical device. And the one that we use at my facility is called the FemoStop. I honestly don't even know if there are other brands out there. The FemoStop device can replace the need for a manual hold by providing very directed and also adjustable hands-free pressure to that access site. So this device, it looks like a bar. It's hard to describe it. I will put in the episode notes or the actual blog that goes along with this. I will link to a picture of a FemoStop so that you can see what it looks like. So it's hard to describe it. It's like a bar. And then on one side of the bar is an inflatable dome, which goes face down over that access site. So, and then it wraps all the way around the patient so that it can be secured down. And then that dome is inflated to be initially 10 to 20 millimeters of mercury higher than the patient's systolic blood pressure for a very brief period of time. It's going to be no more than 3 minutes. We don't want to cause any problems to the limb, like, some tissue damage. So it is then deflated to a level that allows perfusion to come back to the limb, and then it is deflated very, very slowly as they keep a really close eye on any bleeding until it is deflated and hemostasis is achieved. And then we'll talk about what happens next, but that was just talking about the femostop device specifically. And then the patient could have a vascular closure device to achieve hemostasis. So a vascular closure device, or VCD, includes products such as Vascade, Starclose, AngioSeal, Perclose. These are names that you may hear used. And these devices shorten the duration to hemostasis, and they, in most cases, reduce bed rest requirements dramatically. Other benefits of VCDs are that they provide an alternative to that manual compression. They can be more effective when larger vessels are accessed, and they tend to be more comfortable for the patient. Again, also shorter bed rest requirements, and with that, allow for earlier ambulation in most cases. Now, not all physicians are comfortable, I will say, not comfortable with the shorter bed rest that these devices say is adequate. So in most cases, let's say the patient had a manual hold or a mechanical device like a femostop used. Bed rest is typically going to be 6 hours. And then with these vascular closure devices, some of them say bed rest is 2 hours. I've even seen some of them say the patient can get up more or less right away. This makes physicians very, very nervous. So just because you see that a vascular closure device was used, do not make any assumptions about the patient's bed rest. Make sure you're referring to the physician order, okay? And then one other way that hemostasis can be achieved is sutures. In some cases, that internal puncture is sutured closed. This could involve something called a woggle, which I cannot even begin to try to describe on a podcast. But basically, it uses a purse string suture in the application of a 3-way stopcock, which is then on top of the patient's groin site. The suture ends are threaded through the stopcock, which allows for turning of it, which tightens it, or loosening of it to loosen those internal sutures. So if you see a patient come out after one of these procedures with a 3-way stopcock right there at their groin site, at their puncture site, that is called a woggle. It's not super commonly used, but you could see it. And then other times the suture's just closed up and there's nothing on the outside. So with that said, what are you going to be seeing? Again, hemostasis can be achieved in various ways. If it was achieved using a manual hold or a mechanical device like that femostop, chances are the patient's going to have some kind of compression device post-op for a period of time. Very common brand used is called the Safeguard. That is an adhesive dressing with a small inflatable dome. So remember, the femostop had a big dome and applied a lot of pressure. This is a much smaller little inflatable dome. It is filled with 30 to 40 mils of air, and this dome exerts more gentle, continuous pressure for a period of time after hemostasis is achieved and then slowly deflated. Where I work, we wait an hour after hemostasis is achieved with that Safeguard in place, and then we start taking 5 to 10 mils out every 15 minutes, reassess, etc. And we'll talk a little bit more about this further on. But just knowing what the patient looks like, they could have a Safeguard in place. Now, if a vascular closure device was used or there's those internal sutures, many of those times the patient doesn't need any extra kind of pressure on the site. So you're just going to see a little small piece of gauze with tape or a small piece of gauze with a transparent dressing over it. The patient will also be supine, so lying on their back, and in many, many cases, completely flat. Now, again, this will depend on how hemostasis was achieved, if they used a vascular closure device or not, how high risk the patient is for rebleeding, etc. But in some cases, you will see the head of the bed up a little bit. Note that that head of bed angle is not accidental. It is extremely important and will be dictated by the physician's orders. So it's going to be head of bed flat for a certain period of time, or it's going to be something like can raise head of bed up to a certain degree angle. Definitely not more than that, and not if the patient's oozing or bleeding. Now, the other things that you'll notice about this patient is they typically don't have pain related to the procedure, but they mostly complain of back pain. So you're going to see this very, very often. Your patients who've maybe they've had like a cardiac catheterization procedure, which can take a really long time. So they've been on their back in the cath lab for hours. Now they're coming to you for their post-op care where they have to lie on their back for 6 hours. Their backs hurt, man. So lots of complaining about back pain. And that's again due to positioning during the procedure, followed up by extended bed rest. So again, how does your patient look? They could have a safeguard in place. They could have just a gauze dressing with a little transparent tape over it. They could have that woggle, though it's not very common, and they will probably be complaining of back pain at some point. So the next letter in the LATTE method is a letter A, and that stands for assessments. So what assessments are you performing after that sheath is removed? Your patients come to you in the recovery room or the post-op procedure care area. So your priority assessments are going to be basically monitoring for any sign of complications. So what we're going to be doing is visualizing the site. We're looking for bleeding, we're looking for oozing, we're looking for swelling, which could indicate a hematoma developing. Bruising would indicate there's some bleeding going on there. And I will say, here's a little pro tip. Be sure to check between the patient's legs and underneath them as well, because sometimes the bleeding can occur and just dribble down in between their legs, and then you wouldn't necessarily notice it as easily if you were just glancing at the top or the side of the leg. So you want to just be very thorough in your assessments as you're watching for bleeding. Note that a lot of times the patient will come to you and maybe they have a small dot of blood on the dressing, whether it's just that gauze with a transparent tape over it or underneath that safeguard. So what you want to do is confirm with the nurse that is delivering the patient, hey, is this new or was this there, at the time that you put the gauze on? Most of the time, they're going to say, oh yeah, that's been there. It's not new. He's stable. We have hemostasis. We're all good. Document the size of that and keep a very close eye on it so that you know if the bleeding recurs again or worsens or what have you. You just want to keep a close eye on the size of that little dot of blood. Make sure it doesn't get any bigger. In addition to visualizing and looking at the site, we're also palpating the site. So you're pressing all around that puncture site, looking for any firmness and tenderness, which could be a sign of hematoma. Now, it could be slightly tender from the puncture, but for the most part, it's not. You're noting tenderness that's out of proportion to what they had done, especially if it's combined with firmness. Again, sign of hematoma. Now, they could develop a pseudoaneurysm, which would be a pulsatile mass. If you do feel a pulsatile mass, grab your stethoscope and see if it also has a bruit. If you're hearing a bruit, we're looking at very likely this patient has developed a pseudoaneurysm. Another very important part of your assessment is assessing neurovascular status of that affected extremity. So if your patient has the femoral artery or femoral vein on the right groin access, you're really keeping a close eye on that right limb. You also want to check the left limb to basically know what's normal for the patient. So you're comparing side to side, especially in your patients who maybe have some peripheral vascular disease where blood flow might not be so great. You want to make sure you know what their baseline is. So I find it's always helpful to assess both sides. So you're monitoring that peripheral extremity for any signs of ischemia or altered blood flow. You're looking at their pulses. And a lot of times you will need to use a Doppler for this. So make sure you have a Doppler ready if you are getting a patient post-sheath removal. And hopefully the nurse who took pulses initially marked their location. If they didn't, you be that awesome nurse that marks it so that it's easier for you to find when you have to do this assessment again in a few minutes. And then it's easy for the next nurse to find as well. So you're looking at pulses, you're checking capillary refill, color, temperature, sensation, movement, and edema. So basically a full neurovascular assessment of that affected extremity. You're also monitoring the dressing. It's important to make sure that it is clean, dry, and intact. And if you are working with a patient who has a safeguard, then you are looking at that to track how much air is in the dome, to know how much pressure is being applied. And we'll talk more about the interventions related to managing the safeguard in just a moment. Other key assessments, you're watching your patient's vital signs, you're watching their pain level. Again, pain is a lot of times associated with positional back pain, but back pain, flank pain, abdominal pain could be a sign of retroperitoneal bleeding. So we're taking all pain complaints very seriously and doing a full evaluation. And then vital signs, hypotension, tachycardia associated with bleeding. And if we're seeing hypotension and tachycardia, then we definitely missed some earlier signs of bleeding. So hopefully we don't get to that point. Hopefully you see the bleeding way before we get to that level, but you do want to be assessing vital signs just the same. Let's take a quick break and then we'll come back and look at tests, treatments, and patient education. You know those days when you finish a long shift, but you still want to meet friends for dinner and changing your outfit feels like a one step too many? That's exactly why I love Quince. Their pieces are elevated but effortless, so you feel comfortable and still look really put together. Quince designs everything with layering and real life in mind. They've got the wardrobe staples 100% covered. With organic cotton sweaters, premium denim with stretch that's comfortable all day, and luxe cotton cashmere blends that work perfectly for changing seasons. These are the kinds of pieces you can throw on after work and head straight out the door. I feel like I'm always reaching for my Quince tees. They're absolutely fabulous, and cashmere sweaters. They're high quality, timeless, and make getting dressed completely effortless. What really sets Quince apart is they work directly with safe, ethical factories and cut out the middlemen, so you're not paying for brand markup. Just high-quality clothing made with beautiful materials like European linen and organic cotton. Refresh your wardrobe with Quince. Go to quince.com/nursemo for free shipping on your order and 365-day returns. Now available in Canada too. That's QUINCE.com/nursemo to get free shipping and 365-day returns. Quince.com/nursemo.
Ready to relax in your dream bath retreat without the stress of figuring out every detail yourself? At the Home Depot, your bath upgrade is covered. Shop fully designed rooms and curated bath collections to go from inspiration to transformation fast. Savings of up to 40% will make it easier on your budget. And find everything you need, from tubs to toilets and all the tile in between, to bring your vision to life. The Home Depot. Dream baths built here.
So the next letter in the LATTE method is a T for tests. So what tests might you see conducted for a patient after sheath removal when you're doing groin management? So routine testing really isn't something done after sheath removal, though tests you are interested in would be those that relate to the patient's coagulation status. So I would say you're looking at the CBC to determine their platelet count, since thrombocytopenia is going to put the patient at high risk for bleeding. It's also a really good idea to know the patient's baseline hemoglobin so that you can compare it later on if bleeding does occur. Coags, if you have coag studies available, you're looking at them. You're looking at the PTT, the APTT, the ProTime, the INR, those things to see what their bleeding risk is. And then if there is a complication, the patient could have an ultrasound to evaluate a pseudoaneurysm that's suspected or very large hematoma. And then a CT scan could even be conducted if a retroperitoneal bleed is suspected. So the next letter in the LATTE method is a T, and that is for treatments. And this is where a lot of your work is going to be aimed. We did a lot of assessing, and now we're going to be doing a lot of treating. And most of your interventions during this period are basically aimed at preventing bleeding increasing patient comfort, and managing the safeguard if one is in place. So, really important first off that we are maintaining bed rest. The physician is going to order a specific duration for the bed rest, and this typically can range from 2 to 6 hours, and it will depend on methods used for hemostasis and the patient's condition. With that, we want to make sure that we're keeping the affected extremity flat and still. We don't want the patient wiggling all over the place, and maintain our head of bed limitations. So, again, we want to instruct the patient keep the leg still, keep your leg flat for the duration of your bed rest. And then, as far as head of bed goes, if it says flat, keep it flat. I know it can be really hard, especially if your patient's back is hurting, but them's the rules. Sometimes the physician will write orders that the bed can go up to 15 degrees, 20 degrees, 30 degrees. So you could possibly do that. It might be that they have to be flat for 2 hours, then head of bed can go up after a certain amount of time. So make sure you read and understand the details of your bed rest and head of bed orders. Now, when raising the head of bed, I would advise to do so slowly. Even if the head of bed can go up to 30, I'm not going to ramp it up to 30 right away. I'm going to start, honestly, pretty conservatively and maybe go up to 10 and then watch that site for a little bit. Being very, very mindful that anytime we're moving, bleeding could occur, keeping an eye. Then I'm going to go up a little bit more, keep a close eye, etc. Another key intervention is pain or discomfort management. What I said before rings true again. If your patient is complaining of pain, many, many times it's going to be related to their position, and that is going to be back pain. Very, very common complaint when on supine bed rest. Medication may need to be utilized, especially if the patient's discomfort is jeopardizing their ability to lie still and they're putting that site at risk. If the physician has written orders specifying the patient can be log rolled, sometimes you'll see that they have to be supine for 1 to 2 hours, but then they can be log rolled after that. Then this can be helpful to relieve pressure off the back. So just again, really understanding your bed rest and activity orders. You also want to take measures to prevent increases in intrathoracic pressure, because increased intrathoracic pressure is going to put pressure on those vessels and can cause them to bleed. It's really important that the patient avoid certain movements, certain actions. Things that increase intrathoracic pressure include coughing. That's a big one after these procedures. Sneezing, especially if you sneeze like my husband does, holy moly. Yelling, laughing, lifting the head off the pillow to take a drink of water, and bearing down. All of these things increase intrathoracic pressure and should be avoided. Coughing, I realize, kind of involuntary. Sneezing, involuntary. So you want to make sure that if the patient is coughing or they say they have to sneeze, you've got to press firmly on that site, or if there's more than one site, press on both of them to prevent those vessels from bleeding. Now, I will share a little nurse tip for you. A lot of times these patients will need to take medication after their procedures, or maybe they're just thirsty and they want a drink of water. It's very natural for them to just lift their head off the pillow to take a drink of water or to get that pill down. They should not do that. So what I do if I'm going to be, let's say I need to give my patient a Plavix or a Tylenol or something, I'm going to get a nurse friend to come over, and I'm going to have the nurse friend hold pressure on the sites, or the site if there's just one. While they're holding pressure, I'm going to put the patient's bed into reverse Trendelenburg. So we're just going to angle the entire bed so that their head is up without bending at the hips. So reverse Trendelenburg. And then I'm going to put my hand behind their head and lift it for them so that they don't have to use any musculature to lift their head. And then we're going to give them the water, the pill, the water, what have you, while we're in this supported position. And then lay their head back down, put the bed back to the flat position, and then my nurse friend releases the pressure on the site. So that's how I give water or medications to my patients when they are on this strict bed rest so that we don't increase intrathoracic pressure. I have seen it happen where a patient has lifted their head to take their Plavix and an artery has basically popped and caused a bleeding that had to be managed by the vascular surgeon. All right, another intervention is toileting. Helping a patient void while on strict supine bed rest is a little bit challenging. I'm not going to lie. I mean, you think about it. Could you urinate if you were lying completely flat? It's going to be really hard. We definitely want to avoid the patient having to bear down if they feel like they need to have a bowel movement because that would increase that interthoracic pressure. So, most of the time, though, you're dealing with the patient having to urinate. So, to help facilitate that, one trick is to, again, put the bed in reverse Trendelenburg, and that's going to shift urine to the base of the bladder so that is easier for that reflex to take over, that micturition reflex. For male patients, what I have found is that you can place a urinal pretty easily, put them in that reverse Trendelenburg, place a urinal. It's not going to compromise the groin-site because they're still in that flat supine position. But with a female patient, placing them on a bedpan could compromise the site, especially if they are not supposed to be technically log rolled at this point in their bed rest. So if you can use an option like a PureWick external catheter, if that's available to you. Earlier, I mentioned the safeguard and deflating it. So let's talk a bit about safeguard management. So while practice could vary depending on your facility policy, some general guidelines for managing that safeguard are, first of all, we're going to let it sit for 1 to 2 hours after hemostasis was achieved, and then we begin our deflation. So if no signs of bleeding are present, that bulb, that inflatable bulb, is deflated by 5 to 10 mils every 15 minutes. And we do this using a 60 mil syringe. So that's an important thing to note, that when your patient comes to you, they should have that syringe with them. If not, go get one and make sure it stays with the patient. You're going to be performing a full assessment of the site after each deflation and stay pretty close-ish so that any bleeding can be noticed and intervened upon very, very quickly. Now, you do want to be careful not to deflate the device beyond the capacity of that dome, as this produces negative pressure, which can cause some blistering and tissue damage at the site. So when you get the patient from the procedure nurse, you want to make sure you know how much air is in the dome. Typically, it's inflated to 30 mils, though I do believe the dome can go up to 40 mils. So you want to make sure that you know how much air is in there so that you don't pull out more than what was initially put in, because again, it can create negative pressure and cause some pretty significant tissue damage. Now, if bleeding occurs during that deflation process, you're going to reinflate to the previous level of pressure. And in most cases, and this is the really rough part, in most cases, your facility protocol, the physician orders, whatever it is, will dictate that if bleeding occurs, bed rest starts over. So if you're on hour 4 of bed rest and they're on a 6-hour total and it starts to bleed, guess what? We're starting over at ground zero, and patients can be very frustrated by this. So you want to go slow, take things slowly. Now, the fully deflated safeguard can remain in place as a sterile dressing, and this is really helpful in case bleeding does occur later. Then it can simply be re-inflated. Another thing we're going to do as one of our key treatments is resume activity. So once the patient's bed rest has been completed, they don't have any signs of bleeding, we're going to be resuming activity, but we're going to do it carefully. We're going to do it mindfully. We're going to do it slowly. Getting that patient out of bed for the very first time, high risk for that groin to pop. So we want to just make sure we're with the patient, we're baby stepping the whole process and keeping a very close eye as they sit up, as they stand up, as they start ambulating. Now, what if bleeding occurs? We're definitely managing that bleeding. So if the site does bleed, we want to apply pressure until hemostasis is achieved. And this is why my practice has always been that when I get a patient who I'm managing groins for, I'm putting a pair of gloves, one size up than what I normally wear. So I normally wear medium. I'm going to put a pair of large gloves on either side of the patient so that no matter where I'm standing, if they have a bleed, I can throw gloves on very quickly and get right on to putting pressure on that groin site. So I'll just put them right there at their sides, basically on the edge of the bed so that I'm ready. So a tip that I learned recently from a cath lab nurse is that thinking about blood flow and where to apply that pressure. So if the femoral vein was accessed, which way is blood flowing? It's going towards the heart. So we're going to apply pressure slightly below that puncture site. And if the femoral artery was accessed, the blood is coming down from the heart towards the periphery. So we're going to apply pressure slightly above the access site. And what this does is it helps decrease blood flow to where that hole in the vessel is so that we can reduce how much blood is leaking out of the vascular space. Now, if bleeding cannot be managed with a manual hold, we could use a femostop to put that really strong, really consistent hands-free pressure to the area. And of course, anytime the patient rebleeds, we are letting the physician know. In fact, we're letting the physician know if there's any complication, if they develop a hematoma or a pseudoaneurysm, anything that concerns you, you're letting the physician know. And then the patient may need to return to the procedure area. If the patient bleeds and the bleeding cannot be controlled in the post-op setting, they may need to go back to the cath lab or go back to interventional radiology for advanced intervention by the physician. Hopefully that doesn't happen, but do note that it could occur. So the next and final letter in the LATTE method is an E, and this stands for education. So the main theme of your patient education revolves around bleeding prevention and risk management and knowing if bleeding is occurring. So we're going to teach our patient lie flat with your affected leg or legs still and straight for the duration of your bed rest, which could be 2 to 6 hours. Now, in some cases, the patient may be able to elevate up to 30 degrees or be log rolled. I find that it's really helpful to explain all the bed rest and head of bed limitations to the patient in advance so that they know what to expect. If you've got a situation where they only have to lie flat for 2 hours, then they can be log rolled for an hour, then they can go up with the head of bed a little bit after another hour. I let them know so that they realize there is a stepwise process. They're not going to be completely flat the whole time, etc. If they do need to lay completely flat for 6 hours, I make sure they understand that so that they're not continually asking how much longer, because it's a difficult bed rest for patients. And I just want them to be aware of what's going on right from the very beginning. You also want to teach them to avoid those actions that increase intrathoracic pressure, such as coughing, laughing, yelling, straining, or lifting their head off the pillow. If they do feel the urge to cough or sneeze, they need to let you know so that pressure can be placed against the site. You can also teach an alert and oriented patient how to press against the site when coughing or sneezing. Just make sure that they are doing an adequate job because a pretty firm amount of pressure does need to be applied. They should know to let the nurse know if they feel a popping sensation, a warm sensation, wetness, pain at the site, any of those things that could indicate bleeding or a complication occurring. They should know to notify the nurse if they experience back, flank, or abdominal pain. Now, again, back pain can be really common due to positioning. It could also indicate a retroperitoneal bleed, as could flank or abdominal pain. They should alert the nurse if their toes or feet begin to tingle or feel numb, as this could indicate reduced blood flow, maybe a clot developed, maybe bleeding is occurring. I also want to let them know that assessments will be frequent and gradually decrease throughout the duration of their bed rest because, it's a lot when someone's checking your groin site every 15 minutes and your pulses every 15 minutes. So letting them know after a bit, this is going to go down to 30 minutes, and then it's going to go down to an hour, etc. You also want to let them know that if bleeding occurs, duration of bed rest starts over. Terrible, terrible. We hope it doesn't happen. After discharge, they should know that they need to adhere to any activity restrictions, such as lifting heavy objects, for however long their physician specifies. They should avoid submerging the puncture site in water for probably at least a week, The physician will dictate this, but a week is pretty common. That means no baths, no hot tubs, no swimming. And if their procedure specifically involved contrast dye, then fluids will help flush the dye from their system. Now, something I neglected to mention, and my apologies for that, is how frequent your assessments are. So, this will depend on your facility's policies and maybe even the physician orders. But a common cadence would be you're doing those groin checks, you're doing the neurovascular checks every 15 minutes for an hour. So, 4 assessments that are 15 minutes apart. And then every 30 minutes for an hour. So then you would do 2 that are 30 minutes apart. And then every 60 minutes for the duration of the bed rest, or that 4 hours. So a total of 6 hours of very close monitoring. I will say that the assessments will become more frequent again once you start deflating a safeguard if you are using one, or once you start resuming activity, because you do want to be very careful with both of those things to monitor for any signs of bleeding. So there you have it, your quick overview to groin management. It can feel pretty straightforward, but it can also feel pretty high risk because when things go wrong, they tend to go wrong very quickly. And when you know how to prevent complications while you're doing your very thorough assessments and keeping those close eye out for those potential red flags, hopefully you prevent problems, or if they do occur, you catch them very quickly and intervene very quickly. So I hope that helped you, and I will see you on this coming Monday where we will do a little quizzing about this episode. I'll see you then. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.